Good morning. I'm going to just get started. Don't need an introduction because I'm a resident here at UBC in my 5th year, Kiara Hennessey. So I'm going to be talking about the adrenal incidentalomas. A quick look at the objectives for this morning are the evaluation of an adrenal incidentaloma, management, looking at indications for our observation, biopsy, surgery, and medical management, and at the end a closer look at the minimally invasive approaches to adrenalectomy. So just some questions to get people thinking. Just think of the answer in your own mind, and then at the end of this talk we'll go through them again. So adrenal masses larger than this size have been shown to have a greater than 25% chance of having adrenal cortical carcinoma. So A, 4 centimeters, B, 5 centimeters, C, 6, 7, or D, 7, and E, 8 centimeters. Second question, what's the overall sensitivity of adrenal biopsy to detect carcinoma in patients with an adrenal incidentaloma? So 10, 25, 40, 50, or 70%. And then what would be the most specific test to diagnose Cushing's syndrome? The salivary cortisol test, the 1 milligram dexamethasone suppression test, the random serum cortisol test, 24-hour urinary free cortisol, or the random urinary cortisol. Okay, so let's get started. Take off. Adrenal incidentalomas are tumors that are larger than 1 centimeter that are found serendipitously during imaging for other reasons. Adrenal incidentalomas have been described as a new endocrine epidemic, AIDS, so adrenal incidentaloma discovered serendipitously. Adrenal masses are among the most common tumors in humans, 6 to 9% prevalence in autopsy series. This increases with age at 0.2% for those in their 20s and 7% for those greater than 70 years old. 45% of patients undergoing a CT of the abdomen have adrenal incidentalomas detected, and this is increasing due to the higher resolution imaging. The majority of these lesions are benign, non-secreting, and silent clinically. In patients with no known history of malignancy, the majority are benign, greater than 70%. In those with a history of malignancy, 50 to 75% of these lesions are metastases. And overall, 4 to 5% of patients with an incidentaloma are diagnosed with adrenal cortical carcinoma, so it's quite rare, affecting 1 to 2 per million persons per year. Up to 20% of these lesions are functional and secreting glucocorticoids, causing Cushing's syndrome, aldosterone, pheochromocytoma with catecholamines, or sex hormone secreting tumors. So why should every patient be offered testing for these incidentalomas? Essentially to rule out malignancy or a functional lesion. So I just threw in some dog photos because I couldn't think of anything else entertaining to put up this morning. So clinical evaluation, the key elements are looking at the size of the lesion that's been detected, the likelihood of malignancy based on risk factors, history, the appearance on imaging, and then functionality, as we discussed, the Cushing's syndrome, hyperaldosteronism, or pheo. So a good overall clinical evaluation includes a good history, a physical exam, and a biochemical evaluation, plus the imaging that you're presented with. There's been no diagnostic approach that's been prospectively validated, so most of the recommendations are based on the National Institute of Health consensus statement from 2003, and then some review articles with expert opinion. So the goals of history and physical are to look for signs and symptoms of functional mass, detect a malignancy, whether it's a primary malignancy or secondary malignancy from METs, from lung cancer, breast cancer, melanoma, and also to detect familial conditions that have associated pheochromocytomas or adrenocortical carcinomas. This is a busy slide. It's probably better for reference later, but it just highlights some of the symptoms and signs to expect with Cushing's syndrome, pheo, the other hormone syndromes. Just looking down at the bottom with the metastatic cancer, it's important also to ask, again, for the risk factors, if they've been adherent to the age-appropriate screening tests, if they have a family history of malignancy, smoking, and I'm not going to bore you with all the details there. So another interlude. And then, so moving on to biochemical evaluation. So for Cushing's syndrome, about 5.3% of adrenal incidentalomas secrete glucocorticoids, and you want to rule out exogenous steroid use in these patients, and then focus on screening tests, which we'll get into. For pheos, about 4 to 5% of incidentalomas, including patients that are normotensive, will have a pheo. And again, you want to stop any confounding medications, and also then focus on screening tests. And lastly, with hyperaldosteronism, it's rare, about 1 to 3% of incidentalomas secrete aldosterone. And you really want to differentiate whether it's an aldosterone-producing adenoma, as in cons, or bilateral adrenal hyperplasia, and we'll get into that. So for Cushing syndrome, there's been many tests described. In the literature, the two that are recommended are the 24-hour urinary free cortisol or the dexamethasone suppression test. The dexamethasone suppression test actually has a higher specificity of around 97%. So it's the best because theoretically patients with overt Cushing syndrome will have the clinical stigmata. So you're really looking for the subclinical Cushing's in these patients. So this is a very specific test. This is just looking at a paper done by Pecori's group in 2007. It's a retrospective study just looking at the specificity of 3 different tests, the urinary free cortisol, the dexamethasone suppression test, and then the serum cortisol at midnight. And it showed, again, that the dexamethasone suppression test had the highest specificity at 97%. So for pheochromocytoma, the biochemical evaluation includes the plasma or urinary metanephrines. This is more sensitive than doing plasma catecholamines because the secretion of catecholamines may be episodic, whereas their breakdown, and hence their breakdown products, the metanephrines, are more continuous. The literature does recommend a confirmation test with a clonidine suppression test. So you should see the norepinephrine inhibited with the clonidine. And that's just a table with some reference values. In hyperaldosteronism, this, yes? Pardon me? Oh, okay. The metanephrine. Okay, thank you. In Canada. Okay, thank you. Primary hyperaldosteronism, the syndrome includes hypertension, hypokalemia, alkalosis, and hyponatremia. However, 40% of patients will be normocalemic, so simply doing the electrolytes screening for hypokalemia is not a reliable screening test. So it's recommended to actually combine this with the aldosterone plasma renin activity ratio with a greater than 20 ratio suggesting the diagnosis. And it's also suggested that this should be confirmed with an aldosterone suppression test, so loading the patient with sodium with a saline challenge to confirm that the aldosterone is suppressed. And then if and only if the confirmatory test is positive, moving on to the lateralizing test with adrenal vein renin sampling. With adrenocortical carcinoma, the biochemical evaluation, it's relevant, but because the tumor is so rare, it's not recommended as a routine screening test to look for excess androgens or estrogens. However, about 60 to 80% of these will have hormone secretion. So this is a summary here. Again, this is probably better for reference later, but for Cushing syndrome, just highlighting the dexamethasone suppression test is the primary, most specific screening test, ruling out any false positive causes such as medications, and then moving on to confirmatory test, something such as a corticotropin level, showing that the corticotropin is decreased due to the high cortisol levels. With pheo, again, using the fractionated metanephrines or other tests as your first line, ruling out any confounders, and then using confirmatory tests as necessary. And with plasma or hyperaldosteronism, looking at the aldosterone level and the aldosterone plasma renin ratio, and plus or minus the electrolytes with the potassium. Moving on then to an aldosterone suppression test to confirm the elevated aldosterone, and lastly the lateralizing test if the confirmatory test is positive. Another break. So moving on to imaging, I just wanted to focus, basically you're usually presented with a CT and sometimes an MRI. So I just wanted to look at the basic imaging characteristics of the main lesions. So for adenomas, they're usually small in size, less than 3 centimeters. They're round and oval with a smooth, homogeneous characteristics. They're usually solitary or unilateral, less than 10 Hounsfield units on unenhanced CT. That's due to the high intracytoplasmic lipid content. However, it should be noted that about 30% don't have enough lipids, so it's not a reliable screening, or not a reliable test to determine that it is an adenoma. However, the sensitivity and specificity of the washout after contrast is very high. In the literature, it states it's 100%. And that would be that the washout is rapid with greater than 50% at 10 minutes of contrast. And on MRI, they are iso-intense with the liver on T2 weighted imaging. Necrosis, hemorrhage, and calcification is rare, and the growth rate is usually stable or slow. Looking at the carcinomas, these are different. They're larger. They're usually greater than 4 centimeters. Irregular, unclear margins. They could be heterogeneous with calcification, necrosis, or hemorrhage. Usually they are solitary or unilateral, greater than 10 Hounsfield units, and often greater than 25 on unenhanced CT. And then they do show a slow contrast washout with less than 50% at 10 minutes. And on MRI, they'll show a hyperintense appearance compared to the liver on T2 weighted imaging. Their growth rate is usually rapid at greater than 2 centimeters per year. With theos, these also are larger lesions, usually greater than 3 centimeters. They're round and oval with clear margins. They do have a heterogeneous appearance, and they can have hemorrhage, cystic areas, necrosis. They're usually solitary. On unenhanced CT, they're often greater than 25 Hounsfield units on unenhanced, and then have a slow washout with less than 50% on contrast scans at 10 minutes. And their appearance on MRI is markedly intense, the classic light bulb. I think I've got a picture, sign on a T2 weighted MRI. And lastly, metastases. The presentation size can be variable, frequently less than 3 centimeters. Again, they can be oval or irregular, heterogeneous, often bilateral. They're also greater than about 25 on unenhanced CT, and they have a slow washout of contrast 2 at 10 minutes. They are hyperintense on the T2 weighted MRIs, and they occasionally can have hemorrhage or cystic areas, and their growth rate is variable. Yeah. Yes? Yeah. Adrenal. Thank you. PET-CT, apparently in the literature it's highly sensitive, but it's with benign lesions also, these will highlight in 16 to 20%, so it's a poor screening test, and it's useful in patients with a history of malignancy looking for metastases. The MIBG scan, used in specific clinical scenarios, if you're looking for extra-adrenal theo extension, so if the lesion is malignant, familial or pediatric syndromes, and also in a silent theo clinical scenario where there's high clinical suspicion that the biochemical evaluation and imaging is negative. So role of biopsy, it's quite limited in adrenal incidentalomas, trying to differentiate benign from metastatic lesions. Those with a known extra-adrenal malignancy, it has about a 70% detection rate of malignancy. However, comparing a benign adrenal lesion to adrenal cortical carcinoma, the sensitivity is quite poor at only 50%. Just a note as well, if biopsy is to be entertained, that the biochemical evaluation should be done first to rule out a theo to prevent a hypertensive crisis. We're going to look into this now with the size of the lesions, but it's actually the strongest predictor of malignancy. So biopsy shouldn't change your management. This is just a study, it's a retrospective review in 2009, just showing again that it's poor at differentiating benign adenomas from adrenal cortical carcinoma, but fairly reasonable at detecting malignant mets. If you can read that. Okay, so moving on to management. Overall, we have observation, resection with surgery, or medical therapy. So determinants of management strategy would be lesion size, the functionality of the lesion, malignant potential, and then the patient themselves with their health status and candidacy for surgery. So looking at lesion size, those less than 4 centimeters, 60% are benign, less than 2% are adrenal cortical carcinoma. Those 4 to 6 centimeters, roughly 6% are malignant, and greater than 6 centimeters, about 25% are malignant. And therefore, all lesions greater than 6 centimeters should be considered malignant, and surgical resection should be considered. Those lesions that are less than 4 centimeters and are non-functional, there's general consensus in the literature that observation is an appropriate management strategy. For those 4 to 6 centimeters, you have to look at other characteristics on imaging, for example, necrosis, calcification, their washout with contrast, the patient themselves, their age, their comorbidities, and then also the feasibility of this ongoing continued surveillance. CT has also been noted to underestimate the size of these lesions. I don't know if some of the radiologists agree with that, but I found that in literature about 20 to 40% of cases will be underestimated. So some authors use this as a reason to suggest exploration at a smaller size. And some will say even 3 to 4 centimeters, especially if the patient is less than 50 years of age, that it should be considered. So functionality, really the option is resection or medical management, and the goals are to prevent the long-term adverse effects of the functional lesion. And you just have to be cognizant of adrenal insufficiency if you're using the medications. So glucocorticoids, you want to avoid the long-term effects of hypertension, diabetes, obesity. For those that are non-operative candidates, you can use the medications that affect steroid production, so aminoglutathione, etiripone, or ketoconazole, and again, monitor for adrenal insufficiency. For pheo, the goal is to resect to prevent, again, long-term consequences in the vascular system, the cardiac system, and also that 10% of these lesions are malignant. For the medical management, I just wanted to use a few slides just to go over some of the perioperative considerations. There's no validated sort of algorithm for the anesthetist as to which medication should be started preoperatively, but in general, most patients are started on something for hypertension, so an alpha blockade is usually the first agent, usually phenoxybenzamine because it's a long-acting, non-specific agent. However, if the side effects are problematic or if long-term hypertensive control is required, then some of the more selective alpha-1 agents should be considered, like prazosin, trazocin. The goal blood pressure is 120/80. Duration of pre-operative treatment should be around 7 to 14 days, longer if there's already pre-established cardiac disease. And you want to load the patients with sodium and IV fluids preoperatively for volume expansion. Beta blockers are also used, again, for hypertension, but also to protect against arrhythmias. These should be started only after the alpha blockade has been initiated to avoid the unopposed alpha effects with malignant hypertensive crises. Also, you want to start slow because the chronic catecholamine exposure can cause a cardiomyopathy, and with a beta blocker, this can be exacerbated. So intraoperatively, obviously you want an experienced surgeon and an anesthetic team. Invasive monitoring lines are often used. Also, you want to be aware of the specific meds that can be used with pheochromocytoma, and those to be avoided. For intraoperative crises, so hypertension or arrhythmias, in general, rapid onset and short duration medications are chosen. For aldosterone-secreting tumors, again, the goals are to prevent the long-term consequences, so hypertension and organ damage, electrolyte imbalances. This is also entertained after the unilateral hypersecretion has been proven with the lateralizing tests, and some studies quote a hypertension cure rate of 33 to 70%. Those that are poor operative candidates can be offered spironolactone, which is a competitive aldosterone antagonist. Yes. Non-functional reviews. Patients. Sorry, what are you referring to? Oh. Whether they should be taken out or not?
Yeah. Or any way to differentiate.
Yeah. Not that I'm aware of. Okay. Moving on to those lesions that could be potentially malignant. These you want to be, the primary curative treatment is surgery. These lesions do have a high risk of occult micrometastases at presentation, and up to 40% of those stage 1 to 3 will have a malignant mets at 2 years. En bloc resection is recommended, removing the adrenal and any adjacent involved organs. A lymph node dissection from the IMA to the crest of the diaphragm is recommended. And it's controversial in the literature whether a maximum debulking in an unresectable lesion is recommended. However, if a lesion is unresectable and it is untreated, patients will have under a year of survival, 3 to 9 months. And of course, avoiding tumor spillage intraoperatively to prevent recurrence and metastases. Mitotane is a medication. It's a derivative of the insecticide DDT, and it causes necrosis and atrophy of the adrenal cortex. This can be used as a primary therapy in those patients that are poor surgical candidates or in those that have advanced disease presentation, plus or minus a debulking surgery. It's been shown to regress the size of the tumor in 25% of patients and decrease hypersecretion of hormones in 75%, but it has not been shown to prolong survival. And whether there's a benefit for mitotane as an adjuvant therapy after surgery is controversial, but some studies have shown improved recurrence-free survival and overall survival. There's also chemotherapy that is investigated. Different regimens are being looked into in randomized controlled trials, but the response rates are poor, up to 40 to 50%. Other investigational agents are being looked into, and also the role of adjuvant radiotherapy. Some studies have shown decreased recurrence if radiation is applied to the tumor bed, but this again is also controversial, and it has been used in symptomatic bone mets for palliative reasons. Overall, the survival is stage dependent, but it is poor. So 5-year overall survival is 15 to 40%. And the mean survival, which I mentioned earlier, with metastases at presentation is less than a year. Okay, now that I have you all asleep, I thought I'd move on to some of the more interesting parts of the talk, which is surgery. So basically, in general, approaches are open, lap, or robotic. So for the open adrenalectomy, this has been the traditional approach for primary adrenal cortical carcinoma. This was due to concerns about increased risk of recurrence locally, also risk of carcinomatosis or port site mets. In more recent series, this has not been shown, and actually the minimally invasive approaches have shown equivalent local recurrence and survival for metastatic or for malignant lesions. Open surgery is still indicated in larger tumors, especially those that are invasive or involving the adrenal vein, renal vein, or IVC. This is due to a higher rate of local recurrence and care needed in tumor handling. Also, obviously, if the MIS approach requires emergent open conversion. So open approaches, in general, you can use a flank retroperitoneal approach, the posterior lumbodorsal, or the subcostal anterior or thoracoabdominal incisions. Moving on to the laparoscopic approaches. This was first described in 1992. It's now the standard of care for benign lesions. It's been shown to have a lower 30-day mortality rate, less pain, shorter recovery, shorter hospitalization. It does have comparable results, as I mentioned, with malignant lesions as well. The size threshold is continually being challenged, taking out larger tumors laparoscopically, and it has equal safety in the literature for pheochromocytomas as well. So in general approaches laparoscopically, you can go transperitoneal or retroperitoneal, and I'm going to get into some of the port sites and positioning in a minute. This choice as to whether it's transperitoneal or retroperitoneal is really surgeon-dependent and patient-dependent if you want to avoid the abdominal cavity for reasons such as previous adhesions. So this is just a picture here of the transperitoneal port site placement, quite similar to laparoscopic nephrectomy, like triangulating 3 ports towards the adrenal gland. And then on the right side, sometimes a liver retractor port would be required as well. This is just a site variation with all the ports moved up along the costal margin. For the technique in general, it's mobilizing surrounding structures for exposure, and then early ligation of the adrenal vein, whether it's with clips or ligature, and then circumferentially dividing the vascular supply to the adrenal gland and excising the lesion, or excising the gland. Retroperitoneally, the advantages are that you have a direct, fast access to the adrenal gland, that you avoid the intra-abdominal cavity if they've had previous surgery with adhesions. There's been no difference in morbidity or mortality in the literature. Disadvantages would be that the anatomy, the approach is unfamiliar, and positioning, there's several options, either prone or flank. This is just a diagram of the prone or flank port sites. So one of the ports goes back in the renal angle, one just at the tip of the 12th rib, and then one more medial above the anterior superior iliac spine. This is a live, it's a real picture of this approach. It's actually the prone approach, so not the flank. This is the left side. So head is up this way and back towards the other end. This is being done at St. Paul's Hospital. There's a recent grad from UBC that's gone to do a fellowship in Pittsburgh, the University of Pittsburgh, and trained with a physician there that went to Germany to learn this approach by Dr. Waltz. And I just have a series, he has the largest series of this posterior retroperitoneal approach. I guess I wrote his name there, Dr. Waltz. And this is just from his paper. It shows a diagram of the anatomy coming at it from the prone perspective. And at the end of this talk, if I have time, I'm going to play a quick video just showing a right prone approach to the retroperitoneal adrenalectomy. So moving on to robotics, it has been described as being shown to be safe and technically feasible. It has all the advantages that robotic surgery offers: the 3D view, comfortable sitting position for the surgeon, elimination of tremor, all the degrees of freedom of motion. There's not been any prospective or randomized studies comparing laparoscopic and robotic adrenalectomy, but case series have shown equivalent complication rate, blood loss, and hospital stay. This is a small study here that I've just highlighted, and it just shows some of the potential drawbacks. And in this study, it was specifically the overall operative and resection time, the increased cost with longer procedure. So in general, no quantitative significant advantages with the robot-assisted, but the authors of that small series point out that the results will vary dependent on the surgeon's experience, the level of the trainee that's assisting the surgeon, and the size of the tumor, and that in the future this should be considered when comparing robotic surgery to laparoscopic surgery. Minimally invasive adrenal sparing surgery has also been described, both laparoscopically and robotically. Indications would be for small bilateral tumors, or in familial conditions where they have multiple lesions, or if there's a solitary adrenal gland. Contraindications would be a large tumor, anything that's invasive or involving the venous system, or if there's suspicion of malignancy. So the technique would be preservation of the primary adrenal vein, whether it's on the right it would be the middle adrenal vein, or on the left the lower adrenal vein, and then clamping the variable arterial supply using a lap ultrasound to identify the lesion and excising it, which sounds technically challenging. Also, thermoablation with RFA or cryotherapy has been described, and just a note to rule out FEO before manipulating this. Even with RFA or cryo, you could have a hypertensive crisis. So moving on to follow-up, timing for follow-up has been recommended if you're following a small, maybe it's a less than 4 centimeter non-functional lesion, to repeat imaging at 6 months, 12 months, and 24 months. Some authors state that if the size is stable on 2 images, that further imaging isn't required. And functionality reassessment is recommended every year for 4 years. Again, some authors are varying that and saying if it's stable on 2 imaging, that further biochemical evaluation isn't required. For adrenocortical carcinoma, the schedule is chest CT, chest and abdominal pelvis imaging, whether it's MRI or CT, at 3 months for 2 years, and then extending that interval but continuing on for 5 years. The role of a PET CT is not well defined in follow-up. So lesion size, following if there's an increase in greater than 1 centimeter during your follow-up imaging, that your approach should be reconsidered and surgery should be entertained. Typically, however, the adrenocortical carcinomas demonstrate a more rapid growth rate of about 2 centimeters per year. Approximately 5 to 25% will increase by 1 centimeter over 4 years of observation. And the risk of non-metastatic malignancy, so an adrenocortical carcinoma, is actually quite low in follow-up, 1 in 1,000. Other imaging characteristics, as we've mentioned before, necrosis, calcification, anything that's suspicious, should also prompt you to reconsider your plan of action. And lastly, if functional status, up to 20% of these lesions over follow-up will develop functionality. And the majority of these will be cortisol-secreting tumors, and they're usually large, greater than 3 centimeters. So this is just a summary. It's the National Institute of Health, the consensus statement, the most referenced review article by Young in the New England Journal of Medicine, and then the up-to-date, up-to-date reference. It just summarizes, they all basically say the same, that the hormonal test should be done yearly for 4 years, and then the imaging varies whether it's 2 or 3 CTs at different intervals, but roughly 6, 12, and 24 months. So this strict follow-up program has stirred up some controversy, and some authors, Kaywood in Ireland, have sort of evaluated and questioned the benefit and the risks of doing such an intense follow-up for so many small lesions that are being followed. They state that it's reasonable to, at the beginning, rule out functionality, rule out the chance of malignancy, but if you're happy with that, not to continue and pursue follow-up imaging. They then qualify and say that tumors that are maybe in the 4 to 6 centimeter range or show some suspicion on imaging, that a single solitary follow-up study, whether it's an MRI or CT, is reasonable. Some of the thoughts behind their arguments are that the overall endocrine functionality of these tumors is quite low, up to 20%, but often lower. The malignancy rate is low, about 5%. That the majority of the functional lesions are subclinical Cushing's, and whether that's even clinically important with respect to long-term outcome is questionable. They also state that if it's initially benign and non-functional, that the chance of developing a malignancy, as I stated, is fairly low, and that the chance of false positive tests is much higher than the chance of a true positive test in this follow-up regimen. And also, interesting, I'll show you a table. They just equated potentially the chance of detecting a malignancy to that of inducing a malignancy by CT radiation. So this is just a table from their study. I just highlighted the two numbers, the chance of inducing a fatal cancer by CT exposure and then the chance of actually detecting a malignant lesion, roughly 1 in 430 compared to 1 in 500. So this is just a summary of the algorithm. You can read it. Basically what we went through, the clinical evaluation with history physical, and then the biochemical evaluation. If the biochemical evaluation shows a positive result, then going on with confirmatory testing and lateralizing testing, and then entertaining surgery. If the biochemical evaluation is negative, looking at the imaging, whether the imaging is suspicious or benign, and then deciding whether, if you think it could be metastases, talking about a biopsy, or going straight to follow-up or surgery as specified. And of course, I just circled the ones that are controversial, which is the follow-up plan and also the actual size cutoffs in the literature. This whole algorithm needs to be individualized to the patient, their preferences, their clinical scenario, and it's not a hard and fast algorithm to follow, but some ideas. So just touching on those questions again, adrenal masses that are larger than this size have a greater than 25% chance of being adrenal cortical carcinoma, so it was 6 centimeters. What's the overall sensitivity of the adrenal biopsy to detect malignancy in patients with adrenal incidentaloma, not malignant or not metastatic lesions, but adrenal cortical carcinoma? It's only 50%, so it's quite poor. And then the most specific test was the 1 milligram dexamethasone suppression test.